So today I'd like to introduce our two speakers for the day who are going to speak to us on the topic of the toxic drug poisoning crisis and caring for people who use substances. So today we have with us Elizabeth Dogherty, clinical nurse specialist with Providence Healthcare, and Naomi Watt, substance use nurse educator at Providence Healthcare as well. So thank you both for being here, and I will let you go from here.
My name is Liz Doherty. I'm the clinical nurse specialist for substance use at Providence Healthcare. So I started my nursing career here at Providence. In the early 2000s, I worked as a porter ward aide and a PCA in summers during nursing school. And then I started my nursing career on the acute medicine here at St. Paul's. Then I went back to do some graduate studies. And since then, I've worked in general surgery, our urban health unit, which is an acute medical unit. The attending physicians are infectious disease specialists. So we see a lot of patients there with addictions. And so I was the CNL for a bit there. And then I covered someone's maternity leave as the nurse educator for substance use at Providence. And so at that time, and this was only, I guess, like a year and a half ago, we had one nurse educator for substance use for all of Providence Healthcare. And so what I quickly recognized in that role was that the role did involve nursing education, but a lot of the work really was sort of CNS work, systems level, DSTs, policies, research QI, in addition to education. And so we were quite lucky in that our director advocated to have add a CNS as well as a clinical nurse to our team. And then Naomi has gone into the nurse educator position. So we work quite closely together, and I'll let her introduce herself.
Yeah, I also, like Liz, come from working on the urban health unit here at St. Paul's 10C and now 8A, and spent some time also being the clinical nurse leader there. And I've also had some experience working at the Rapid Access Addiction Clinic here at St. Paul's.
So we're super, super grateful to be here, and we're humbled to be presenting this session. And so we're going to just give some, we'll get to that in a second, some context around the toxic drug poisoning crisis, and then some nurse-led initiatives that we've been involved in and leading here at PHC.
And you've already made a beautiful land acknowledgement. That's something that we always try to incorporate into any presentation we're making. And for us, in addition to acknowledging the lands that we're on, is tying the work that we do and kind of directly connecting that to truth and reconciliation. And we know that Indigenous people are disproportionately impacted by the poison drug supply. And we know that we continue to witness the systemic racism that impacts equitable access to healthcare.
So like I said, we'll talk a bit about the drug poisoning crisis, look at the prevalence of substance use disorders, and just kind of complexity of the patients that we're seeing, at least in our practice here in Vancouver, and talk about some innovations in nursing care, and then also some program challenges and successes as well. These are current or recent headlines. And so if you're not familiar, but 2022 is on track to see the highest number of deaths due to toxic drug poisoning ever recorded in a single year in BC's history. And sadly, this is verbatim what we said last December for 2021. And this year is looking to top that record-breaking number. And so given the severity and compounding nature of dual public health crises we're facing, we are really grateful to present this update and overview. But really, it's sobering. Maybe that's not the right word, but it's not, doesn't seem to be getting any better, and it continues to be worse. And we'll talk a bit about that. And in the corner there is a photo that I took from the Moms Stop the Harm website. And so for those of you who don't know about Moms Stop the Harm, that's a network of Canadian families who are impacted by substance use related harms and death. And they do a ton of advocacy work and demonstrations and talk about our failed drug policies. And so often around Overdose Awareness Day and other days, this is an example, of course, from Vancouver, where they're holding crosses, of people to represent people or family members that we've lost. These figures might also be familiar to you all, but we have yet to see a public health crisis of this magnitude in our region. And unfortunately, like I said, it continues to worsen. And so when we consider the average age of someone who dies of an overdose death, it's between 19 and 39 years old. And so we can understand why there's a staggering loss of years. So drug toxicity is actually now second only to cancers in BC for potential years of life lost. And as one mom from Moms Stop the Harm, her name's Marlise Williams, she says, you know, our children are supposed to learn from their mistakes, not die from them. And so we actually regularly have colleagues come to us after presentations that we do, you know, telling us of their loved ones that perhaps they have lost to overdose, or their loved one who, you know, is still, you know, enmeshed in their addiction. And every day they hold their breath, sort of like waiting for that call to say that they've joined the staggering list of numbers. So it's really starting to affect everyone, really. Oh, I was gonna change the number on this slide, but the new average is we're losing about 5.5 British Columbians every day of toxic drug poisoning. And we also know that people who experience intersectional oppression, and as Naomi mentioned, in particular Indigenous people, they're at much higher risk of overdose death. Not because there's a higher prevalence, but less resources and accessibility, as well as experience of racism in healthcare, meaning they do not have equitable access to healthcare. So I like this slide here. Oh, my number's off. But in fact, over 2 times the number of British Columbians have lost their lives due to toxic drug poisoning as compared to COVID-19. And so it's very clear that a large scale investment is urgently required to have an impact on these numbers. You know, we've seen firsthand how quickly and effectively, you know, our city, our region, our province, our country can respond, you know, in the instance of COVID, when so many are at risk in our society. And so COVID-19 has really proved that this is possible, but yet the rate of overdose deaths continues to climb, and our services directly working with those at risk of toxic drug overdose continue to struggle to meet the needs of our patients. And so at Providence Healthcare here in Vancouver, we are seeing an unprecedented demand for addiction services. So since 2018, so we have a rapid access addiction clinic at St. Paul's Hospital. It's an outpatient clinic. It's open 7 days a week. Anyone can come self-refer, walk in for help with their substance use disorder. We have social workers, physicians, nurses, and we start people on treatments. It's designed as sort of a stabilization clinic. So once we stabilize someone on a treatment plan or a medication, we then will, our goal is to transition them to community providers. And so just looking at these numbers here, I mean, since 2018, we've seen an over 323% increase in the volume of patients that we're seeing at RAC, and active patients means somebody who's been seen within the last 6 months, with our average length of stay being about 124 days. And already just in the first 9 months of 2022, we've already seen a 40% increase in active clients since December of 2021. And what's interesting to note about this is that this has been without an increase in staffing or support. And so we are currently struggling to meet the demand with our current level of staffing. We do have to turn people away weekly. And the RAC is one of the lowest barrier clinics that exists, and it sort of breaks our hearts and our colleagues' hearts, and it's morally distressing for people accessing care when we have to turn them away, as we know the reality of the toxic drug supply out there, and that people can and are dying every single day. And then there's also what's called a window of opportunity, when people might be willing or wanting to get help with their substance use. And if services aren't available on demand, we kind of might lose these opportunities with people. And it's just another slide here. So at St. Paul's Hospital, we have an addiction medicine consult service. So we're a consulting service. We don't admit people, but we will see people to support them with their substance use while they are hospitalized. And so we're missing some data here in between 2018 and 2019, but year over year, we've seen a huge increase in the demand and utilization of our expertise. And our team has completed over 10,000 consults over a 17-month period between November of 2019 and March of 2022. And what that looks like on a day-to-day basis is we're doing approximately 12 new consults per day with our inpatient team.
We just always like to bring up this quote, and I feel like everyone, you know, we had such incredible guidance through the COVID pandemic from Dr. Bonnie Henry. And, you know, I just always like to put that quote up there because we wish that we would, you know, follow so much more of her guidance when it comes to responding to the overdose toxic drug supply. We often get asked this question, like, how can it just keep getting worse? And so, I mean, we kind of have a few talking points that we usually address. I mean, it is a very complicated situation, but probably one of the first things that we talk about is it's what's called the iron law of prohibition. And that means that regardless of what substance we're talking about, when you make something illegal, inevitably it's going to increase in concentration. And that's because people, it's an unregulated, it's definitely dominated by organized crime. And so people want to maximize their profits and facilitate transportation without detection. So making something for making a more concentrated product is going to make more money. It's going to avoid the criminal justice system and it can be easier to move around. So we saw that with prohibition of opium, that what gave rise to heroin. Our great law enforcement efforts against heroin have given rise to fentanyl. And we saw this during alcohol prohibition, hence our little picture there. I mean, the most common alcoholic beverage consumed prior to prohibition in the 1920s was beer. And quite a low concentration alcohol. And we know what came out of prohibition of alcohol was moonshine, an incredibly concentrated supply of alcohol that was very dangerous, caused a host of, health issues, if not death, and is largely one of the reasons why we no longer have prohibition of alcohol. And so with this unregulated supply, it also goes hand in hand with contamination because there's no way to have any checks and balances. So currently we're looking at about I think the most recent statistics of our street supply of opiates, which is fentanyl predominantly, are contaminated with benzodiazepines. And the sedative effects of benzodiazepines, they kind of can mimic some of they are very similar to the effects of opiates, and they can enhance the effect of opiates. And it's also legal. So it's easy to transport atazolam, which is a veterinary grade benzodiazepine. That's also very hard to detect in some of drug testing. So it's very advantageous, and even further compounding this contamination is that benzodiazepines are not reversible with Narcan. So when we have people overdosing on this contaminated drug supply, those overdoses have just become more and more complicated for us to treat. I think that, with the closure of the borders, we saw this really kind of huge jump towards the contaminated supply where and also this huge increase of fentanyl, and that's largely around transportation issues because of all the border closures and the port closures. And the other piece that was such a is a real dual challenge with COVID was that there was this parallel experience of people having an acute and long-term source of stress, loss of employment, complete isolation, which we know is going to lead to more substance use across the board. And we've seen that statistically across Canada. And then also at the same time with COVID, we saw this reduction in services. So literally doors being shut everywhere. I was myself working in the Rapid Access Addiction Clinic that March when everything shut down. And it honestly felt like we were the only place that was open. Everywhere people were coming to the door and begging us to open the door so they could use the bathroom or have a cup of water because everything had closed. And one of the stories that really stood out to me, because it was the first, and sadly the first, but many people after that came with me the same kind of telling me the same story. And this woman came in, she was just so devastated and ashamed from having a relapse for alcohol use. And she was really carrying this enormous amount of shame and guilt and just telling me what a failure she felt like. And we started to have a discussion about, so where were things at before this happened? And she was telling me, well, before, everything shut down, like I was going to AA in person every day. I joined a sober hiking group, and then I was going to therapy. And then everything went online, and she just was so isolated. She was working at home online. She wasn't able to access the same resources, and she carried that weight of her relapse all on herself. And my heart just went out to her. I was telling, for what it was worth, telling her, we kind of collectively held that responsibility. And that, not to see it as her own personal failure, but it was kind of, like I said, it was the first of many coming in waves of people with a very similar story. And that being kind of looking at how services and resources are allocated, and seeing, you know, we've had this huge jump towards virtual care, which is wonderful and does for some people make things more accessible. But what if you're homeless, or you don't have housing, you don't have access to a computer or a smartphone? Then all of a sudden that whole aspect of care is not for you. And then we also see this lack of resources on so many levels, you know, provincially and municipally, access to detox or recovery, access for counseling or direct services. One of the things that's really striking right now is the rise in overdose deaths via inhalation. So we kind of have this sort of stereotypical picture of the person who's dying of an overdose death with a syringe in their arm. But the reality is, in Vancouver alone, over 50% of our overdose deaths, that fatal mode of consumption is inhalation. And then across the province, certainly in our northern communities, we're looking at 3/4, more like 75% of folks that are dying of overdose death have inhaled that fatal dose. And yet, when we look at the resources that are available, say around supervised inhalation, it's woefully inadequate. So in Vancouver, in the Lower Mainland, we have 12 overdose prevention sites, and only 3 of them permit inhalation. So we're leaving countless of our, you know, community members at risk to die alone. This is a sort of a bit of a shake it up statement. When we look at the national statistics, I didn't make this stat up, 21.6% of Canadians would fit the diagnostic criteria. Doesn't mean that they have that diagnosis. But I think that that is a pretty significant number, and maybe in some ways surprising, in other ways not. But at the baseline, we know with that number, it doesn't matter what area of medicine, healthcare we're working in, we're going to be working with people who have substance use disorder. We know that, and certainly when I'm working at the Rapid Access Addiction Clinic, I see that full spectrum, all socioeconomic stratas, ages, backgrounds. It's really all represented. On the inpatient side of things, we do see it much more complicated. And we really see that there's a much more complicated picture there. I don't know if you want me to, one thing we often talk about is, like, we hear people say they don't have as much information. How come I don't know about this? That's, you know, a big part of my job as an educator. And so one time I was curious, I was like, well, we know so much about diabetes. I wonder how many Canadians have diabetes. And so I looked it up, and it's 8.6% of Canadians go on to develop diabetes. And I was like, that's interesting, because we learn about diabetes a lot in school. We learn about it all the time. I feel like even people who aren't medical professionals know about diabetes, they know about insulin, they know about hypoglycemia and hyperglycemia. So I was like, that's interesting. Then sometimes I really think the worst stigma is a lack of education, and just the impact that has. And in particular, a piece of education that's so pivotal is looking at, you know, if we consider that 21.6% as kind of the top end of this, and then it's sort of like as people have these other compounding issues, and really at the end, particularly on the inpatient side of things at St. Paul's, is we're dealing with an incredibly complex situation that's not always recognized in our healthcare system. That level of acuity, you know, this person might be walking on and off the unit, going for smoke breaks. They seem, you know, pretty stable in that regard. But the reality is this person has such an acuity, and a social acuity out of those social determinants of health. Yeah. So I think, you know, we often think about one of our patients that we've known now, gosh, I don't know how many years we've known. And he kind of encapsulates this concept really, really clearly for us. I'll call him Ollie. And, you know, I think well over a decade we've known him, and over the years we've gotten to know a lot about his story. And so we know that, you know, he was in the foster care system, that he was bounced around, and that in care he experienced repeated, you know, sexual, physical, emotional abuse, and that he experienced severe neglect and food insecurity, and that he was very early on engaged in the criminal justice system, you know, has, you know, experienced at times daily occurrences of violence, both on the streets and in the prison system, and has acquired brain injuries from overdoses, as well as just the kind of violence of living on the streets. And he can be quite challenging when he comes into the hospital. And again, he's this person who maybe he comes on the unit and he might be walking on and off to go and smoke. And we can, look at this person and assume that they're a stable patient with a predictable course of care. But we know that he requires a specialized care plan and a healthcare team that's not only aware, but has the education and resources to adequately address that complexity of his needs. Yeah, I guess this is more of my point around seems to be something that we really repeatedly come up against, and people asking us for this information. It's still not standardized information that nurses receive in nursing school, and even physicians receive. So I think that it's so challenging for people to be working in this area kind of without the information that they need to be safe for the patient and themselves.
So now I'm just going to talk about some of the interesting and innovative things that we're doing at St. Paul's that I mentioned are nurse-led. But the first thing I'll start with saying is that we have a philosophy of care at Providence for patients and residents who use substances, and it's actually a policy document. And so this document actually provides the foundation for a lot of the work that we do, and it includes language around harm reduction. And so it's scientifically backed, it's evidence-based. It was developed primarily by our nursing director of our program. But what it does is it sort of helps us look at this move away from a moralistic focus on substance use and instead focus on preventable harms. And so what it looks like in practice is that instead of requiring patients to stop using to be able to access healthcare services here, it means we can offer a number of care options to meet patients' individual needs. And it also means that we can have conversations with people about their substance use. They don't need to hide it from us. They may have experienced at other healthcare organizations where, if they are using, they might be denied care. Like that most of the time doesn't happen here. But these conversations are really important, especially in the context of this drug poisoning crisis that's worse than ever. Like we need to be talking to people and how we can support them and reducing some of these harms. So this was before my time working in urban health, but adjacent to St. Paul's, there was an overdose prevention site that was opened in 2018. And it was the first site that was sort of outside the downtown east side. And so it opened in 2018 and it started as a tent, like literally a tent in this picture here, out in the parking lot, in Thurlow parking lot. And then it moved into a mobile trailer type location, still in the parking lot, and it was managed by Rain City. And so Rain City provides housing and supports for marginalized people who face mental and substance use issues. And so the site was staffed by peers. It was supported by Vancouver Coastal Health and sort of Providence. We informally supported them. Like during COVID, we were giving them PPE supplies and we would do some stuff with the peers there and do some education. And that site actually was planning to move, and it has moved. It's moved about a 5-minute walk away from St. Paul's. And so, but what we knew was that 20% of the visits to this site, which also served the community, 20% of the people accessing this site were inpatients of the hospital. And so we thought, how are we going to continue to offer this service to our patients, our inpatients that are accessing this site? And so what we did in a matter of weeks was open an overdose prevention site inside St. Paul's. So myself and Carlin Patterson, she's the CNL of the overdose prevention site. She's also a nurse educator for our urban health unit. And so in a matter of weeks, we set up this site inside St. Paul. So it's an indoors, it's right by the cafeteria. The goals of the site, we want to reduce unwitnessed overdoses in and around the hospital. We want to reduce substance use on the inpatient units and in the ED, reduce medical complications related to substance use by providing education and safer use supplies, reduce patient-initiated discharge, and we just want to improve patient care experience at St. Paul's for patients who use substances, and we try and provide a safe and welcoming space. And so super nurse-led, like it was literally just Carlin and I. And so the staffing model, we have 2 LPNs. And so we thought we really wanted to include peers, so people with lived experience of substance use. However, it was more palatable at the time to have nurses there, given that inpatients have some acute medical needs going on. So perhaps it's, perhaps safer to have nurses accessing the site. We try to make it as low barrier as possible. So it's staffed by 2 LPNs. We're open 10 a.m. to 8 p.m. We serve inpatients. We'll also see outpatients and as well as patients in the ED. But having said that, we're not going to turn people away if they show up here. But we offer supervised injection, overdose prevention response. There's drug testing that we can do there. It's a safe, clean space. We offer sterile supplies, sterile injection supplies. We also offer safer smoking supplies, although patients can't smoke in the site, and we'll talk a little bit more about that later. But the other thing that we do, and I'll talk about a study that we're doing, is nurses can provide harm reduction education around patients who might be using their medically necessary IV lines to inject. So I'll talk a bit about that in a minute. But yeah, it's a really interesting experience, and I'll talk about some of the lessons learned. But yeah, you can see these stats are from September. We've had 3,000 visits for supervised injection, 131 overdoses managed, 12 code blues called, which I'll talk a bit about that. No transfers to ICU. And the other thing is we know that people don't stop using, at 8 p.m. and overnight. And so we are trying to advocate for extended hours, as well as the hospital will be opening a new site at some time, and there aren't currently plans to include this OPS there. But what's interesting is we see an average about 8 to 10 supervised injections per day. A lot more people are smoking. But it's interesting because leadership tends to focus on those 8 to 10 visits, and that sort of like 2 nurses were paying for this number of hours a day, but it's only for 8 to 10 visits. But what I think sometimes we're missing is that bottom line on the graph there, which is the other additional harm reduction services we're actually offering people in terms of take-home naloxone kits, sterile supplies, drug testing. And so it's just been really interesting in some of the advocacy work that we're doing to advocate for extended hours and an actual specialized or space that actually is appropriate, and not sort of like where we're retrofitting some room that already exists. Like, I think we really need to plan this mindfully. So we actually published a paper in the Harm Reduction Journal about implementing this nurse-led overdose prevention site. So you can look that up, it's open access, but I thought I'd briefly just talk about some of the lessons that we learned in doing this, Carlin and I. So engagement, engage people early and often, and that includes staff and leadership, and as well as our emergency response team. So I think we were pretty good. We talked to the nurse educators from critical care, but we failed to include the physicians. And I think we noticed that quite quickly. Like, we were very quick to call code blues in the beginning when patients were perhaps overdosing. And I think at the time, I think the staff were still getting used to it, and we were kind of, just basically, how do I say? We changed our overdose response from like how the rest of the hospital would operate. So, normally, like say on the unit, you might find someone in the bathroom who's down, and so you're not really sure, you might kind of escalate the care a little bit more quickly. But at the OPS, if someone comes in, they're alert and oriented, they use, like, we can sort of assume that this change in their presentation is related to an overdose. And so we actually we changed our protocol, our overdose response protocol, for the nurses to actually be able to administer additional doses of naloxone before sort of escalating care. But it became quite clear after the first few code blues that we called that, we forgot to involve physicians from critical care as well as sort of on the units. And I think the physicians were surprised that there was no physician associated with the OPS. So the way that the OPS works is to make it as low barrier as possible. We have patients come in, unless they overdose or we have to provide some sort of clinical intervention, we don't let the units know that they've accessed the site, which would have been the same if they were going to the outdoor site in the parking lot. We in the hospital would have no idea. that they were there unless they got brought back, through the ED or from EHS. So that was interesting. And so we kind of, what we did is now if we do call a code, we actually call the MRP for the patient. So the nurses can look people up in the computer and we will call them down. But in any event, like we didn't consider all the people that we could, but I think we kind of noticed that really quickly and we were able to mitigate that. Just communicating organization-wide, it was outside the cafeteria, so we needed to engage with the staff there. I kind of talked about access and how we wanted to make it as low barrier as possible. We do get patients to give us their name, but like I said, we won't let anyone know that they've been there unless we have to provide some emergency care. One thing we realized that staff on the units really were unfamiliar or didn't know much about how to provide post-overdose care to patients. So when a patient would overdose at the site, say we reverse their overdose, the nurses there, we will take them back up to the unit where they're from. What we found was the nurses on the units really, most of them didn't really understand, okay, what do I do? How do I monitor post overdose? And, when might I call a physician or when might I give more Narcan? And so we developed a one-page practice pointer and did a bunch of education around post overdose care and monitoring on the unit if someone's, brought back post overdose. Data collection was another thing that we just kind of got this up and running so quickly. We didn't really plan. We do have a data collection sheet, but we've since altered it based on kind of the data that we kind of want to look at. So one thing I can mention is that we did have a row in our data collection sheet for supply pickup. So patients can be given safer IV use supplies and safer smoking supplies. So given that we thought that more people were smoking, and maybe that's why we're not seeing many visits for supervised injection, we changed our data collection sheet to look at, okay, are most people picking up smoking supplies or IV supplies? And so we kind of adjust that as we go. And we've just started working with our data analytics team to develop an online database where we can enter things online instead of having things on paper. So that's taken us some time. The other thing we need to consider was sort of safety. And I think what I'll say about that is the site is not on the same floor as any other acute care unit. So the staff there are pretty, alone. And after the cafeteria closed, it can be pretty vacant. So we've had to look at an increased presence of security for support if needed, and how we kind of manage that. But I do want to talk quickly about the inline study. So when patients were accessing the overdose prevention site outside, the peers were telling us that patients are coming in, they're using their IV lines. What do we do? And they were seeing all kinds of strange things like people using bottled water to fill syringes and inject, or one patient was actually boiling water and putting it in a syringe to flush their medically necessary IV lines. And so we ended up just saying, like, we need to do something about this. And what do we do? There was an extensive ethics consult that was done. We often involve ethics in discussions about the care we provide. But what ethics found, they did quite an extensive ethics review that I'd be happy to share around, like, what do we do with this? There's not a lot of evidence on patients using their IV lines to inject, and what are the health outcomes from that? But they said it was ethically permissible. Like, we can use the knowledge that we know around how to keep, a line sterile or decrease the risk of any complications related to the IV line, that we do as nurses. And so we can provide that education to patients, because if they're going to be doing it, we should be educating them and providing them with the supplies sort of that they need. And so we actually applied for a research challenge grant, and this involves some of our colleagues. And so we're looking at exploring the experiences and the, what happens to people who inject into their drugs into their medically indicated IV lines. And so we've surveyed patients, asking them, how did you learn how to do this? Was it through a peer? Did you watch your nurse? And you're trying to replicate what they were doing. Do you know what the risks are? Do you use the IV every time if you have an IV, or do you muscle or inject substances? And so it's been super interesting. We did surveys, we did interviews, and then we're also looking at patients' charts to see, did they require replacement of a line due to complications? And so we're just sort of analyzing all this data. This was a totally nurse-led study, and I'm super excited about, getting into this data more, because it's relatively unexplored.
And as Liz mentioned, we don't currently have an inhalation space that's available for patients. Our OPS can only supervise injections. And so in order to provide an equitable access to care, and also address the nursing concerns that often come to us about people inhaling substances at the bedside is we have our nurse managers, Bryn Grierson, and also our director, Julie Lajeunesse, and Carlin Patterson, the CNL and of the OPS, doing, really at the forefront of advocacy with Providence Healthcare around an inhalation expansion of our OPS services. And we found maybe surprised a little bit of unlikely allies with OH&S, or Occupational Health and Safety, as they're the ones who are receiving the calls from staff who are concerned about their own safety. So really trying to work closely with them to try and find a solution. And I just came across this quote by Stacey Bork, who's the executive director of a harm reduction agency in Alberta. And they were the first to have the first Health Canada approved safe inhalation site in Lethbridge, Alberta. And this was a quote from her in the article that I found. So I really love that, that sort of rebuttal of the common and, not evidence-based comment that when we provide harm reduction services, we're enabling, when in fact, we know harm reduction services across the board tend to actually reduce substance use.
And we see lots of overdoses on our 4th floor garden, where patients are smoking substances. And so we are trying to advocate for just an extension. So if we blew out the wall of the injection site, and if we could use that outdoor space to have people inhale, and we would have nurses there. Other things that we kind of looked at before that were there's a doc and some outreach workers who did a study with pulse oximetry, where patients could go outside to smoke and they'd have a pulse oximeter on that would alert the nurse, perhaps if their sats were dropping. And we even looked at that. We tried that, but unfortunately, what do you call it when the
the bandwidth of the Bluetooth was not going to work out on our garden. We trialed it.
So we
were out there with the oximeter walking around.
But yeah, it's been a really interesting experience, and I find OH&S is been a real ally, and has been really pushing this. And because I know, they're the ones who get the calls about if patients are smoking on the units, nurses are afraid that if they inhale the fentanyl, how's that going to affect them? So we don't know what's going to be possible, but we're hopeful
and persistent. Just kind of briefly touch on a role that is new as of the last year and a half, and this is the liaison nurse, the addictions medicine consult team. So we just have the one nurse. They're 2 nurses, but 1 nurse on at a time to cover for all 7 days a week, and they provide this essential kind of shoulder to shoulder support. And they work very closely alongside with the other members of the addictions medicine consult team. And they can do direct over the phone or, texting support or talking to somebody on the phone, or they go right to the bedside. They're often called in for complex care planning. And what I think something that we find, we know that there's other resource nurses and liaison nurses for other areas. And one thing that I think is so incredible about our liaison nurse is how closely that they're working with our peer support worker. So peer, if someone with lived experience of substance use disorder. And we're just so grateful to have Karen on our team, and she plays such a pivotal role. And we've really had to learn how to incorporate working with peers as this is kind of outside of our rigid healthcare system. And so how do we protect that essential value that they're bringing within the constraints of the healthcare system? And I know that the feedback has been overwhelmingly positive from physicians, from nurses, from the patients and clients alike. Just so we're really appreciative of how much when we work with peers, it does challenge the status quo, and that's kind of telling us that we're on the right track. So we have also, because we have peers that also work at the Rapid Access Addiction Clinic and also at our John Rudy outpatient clinic, the HIV outpatient clinic here at St. Paul's, that we're developing where we are working with our peers so that they can review documents. So as we come up with maybe, conversations conversational tools that we share with other areas. We'll have a peer review that with us, and just to make sure that that really makes sense to them. And we love this quote from Scott, who was our director of urban health, who's now on a medical leave, but we like his bold statement, his bold, we put him in quotes here.
And I think just kind of the evolution of these roles has been really interesting. Like when I was the only nurse educator for all of PHC, I started to get consulted on or involved in, care planning for any patient that used substances on medicine. And what I noticed was when I went to the units is that, like we mentioned earlier, there isn't this sort of mandatory education around engaging with, with patients who use substances. And often it was just like nurses saying that, I don't even know how to start a conversation with someone, or, how do I assess for pain and withdrawal, or and it was so overwhelming. And I think that's part of the reason why when I approached Scott with that, he said, okay, we really need like a nurse who can provide that shoulder to shoulder clinical support. And then we also need a CNS to do all the CNS type work. And then perhaps that frees up the educator to do so much education. And so I think we're really only scratching the surface, but we're a small but mighty team. And Karen's just been like an absolute essential addition to our team. So particularly in, bridging for patients. So if someone's, we're having trouble engaging someone or getting a history from them, she can kind of provide that essential communication between physicians and patients. And she does a lot of work and a lot of great work. But what it's made us realize is she's the first peer that's been hired by PHC.
Yeah.
So our rapid access addiction peers are contracted from an outside agency. And so what we realized quite quickly was, okay, she reports to us as nurses, but who's her support person? Or there's this power differential or perceived power differential. And so how do we really support peers moving forward? And so we are going to go ahead and hire more peers, but we made it quite clear that if we're going to do that, we need a peer coordinator or a peer supervisor or someone who can provide that support sort of in a different way than we can.
Yeah. Yeah. One of the things that we're really excited to talk about at the Rapid Access Addiction Clinic is what we call, it has two names that get used interchangeably. It's a morphine tolerance test, or most commonly referred to as a rapid Cadian titration. And so just for a little bit of background, Cadian is sort of a higher intensity option of an opiate agonist therapy for people that have maybe tried methadone and Suboxone and that's not been effective for them. And it's often used concurrently with other opiate agonist therapies. Somebody could be on Cadian as well as on an injectable opiate agonist. And when people, it takes time for people to get to a therapeutic dose. And for physicians, there's very strict guidelines in the community about what the low dose you have to start someone at, and that you can only titrate up very slowly. Every 3 days, you can go up a minimal amount. And if somebody's missed a medication, after 2 days, there's a 40% reduction in their dose. After 3 days is 60% reduction. After 4 days, an 80% reduction. And again, just reminding ourselves that these are all daily witnessed ingestion. So a person has to go to a pharmacy, wait in line to receive their dose. And if they, they get food poisoning, somebody in their family gets sick and they have to go to the island to visit them and they miss a couple of days, they're coming back to a sub-therapeutic dose. And even to get their titrations, it's going 3 days, going back to going 3 days to the pharmacy, going back to the doctor, getting another prescription, taking that back to the pharmacy, waiting for that one to be filled, going for 3 days, then going back to the doctor. So it's really onerous and time intensive. And when we consider it's in that kind of punitive way that people are being, in essence, punished for missing doses and then being at a sub-therapeutic level. And then already that's really challenging for folks. But then when we put that into the context of a toxic drug supply, it's deadly. Because if people are not at a therapeutic dose and they have to rely on the street supply to treat withdrawal or pain, then they're at risk for an overdose death, because it's a bit of a Russian roulette with the street supply. Even if you know your dealer, it's every dose, you don't know what's going to happen. And so the doctors came up with this plan where, because we have nurses that are at the rack, that they can supervise doses, and they can do this is the morphine tolerance test. So if they can demonstrate their tolerance to the short-acting morphine oral solution, then that doctor can feel confident providing them a Cadian script for the next day that's at a higher dose. So this is the rapid Cadian titration. using a morphine tolerance test model. So, you know, it took a while for the doctors. They came up with this. It's all well and good, but how do we roll it out? And so that was really where the nursing innovation came in, where it was working with those frontline nurses that were doing this on the fly, and then working with the nurse educators and our med safety nurse colleagues to develop the consent form that was really a trauma-informed consent form, and the process, which ironically involved going back to paper PPOs and MARS because of EMR. But it really, you know, when we consider the impact of standardizing this type of process, obviously, number one, patient safety, you know, client safety. We're giving really high doses. We need to make this really safe. And then efficiency. And when we're talking about efficiency at the rack, we're talking about being efficient. That means we don't have to turn people away. And when we turn people away, we know that it's possible that they could die. So I think that this has just been a really big triumph for us. And we're really excited to talk about it, obviously.
Well, and I think like sometimes physicians and our physicians do a lot of really sort of innovative things and practices, but sometimes it doesn't really translate into like, what's this going to look like kind of on a nursing end. And I guess where we saw something similar would be that during COVID, our docs started prescribing IV fentanyl for withdrawal management. So to try and keep patients in the hospital to receive the medical care they need. But guess what? IV fentanyl, the doses that we're giving, the PDTM doesn't reflect that. So nurses were saying, you know, oh, well, I don't feel safe administering this. Like the PDTM doesn't reflect this. And so we had to go back and I went to the physicians. I said, I need you to give me the rationale why you're ordering this. I need you to tell me the exact assessment parameters you want, and sort of giving nursing, you know, some guidance and framework that's been reviewed and working with our med safety colleagues. And we did update the PDTM to reflect this, but it just goes to show that, you know, I love our physicians, but sometimes, they don't think about how things translate into nursing practice and how nurses need to be supported. You know, a big concern around some of the things that we do is around liability. Yeah. We're giving high doses of opioids. Like what would happen if there wasn't in writing? Seems to be like something people want to see, but really making nurses feel safe and supported. And that's kind of also where that shoulder to shoulder clinical support comes in. Like, oh, okay. When we first rolled out the IV fentanyl, it was like, nurses were really uncomfortable, like, oh, I'm giving the patient, you know, this medication that's killing people in community, and kind of walking them through that. And I think with that, it was, I had to ask the docs, you know, what equivalent in, you know, high dose hydromorphone would that be? And how does that relate to kind of dose of opioids that we already give? But I think like, our med safety colleagues, we're like in constant.
We're thick as thieves. Yeah.
So I think we'll just finish with some of the challenges that we encounter with the nursing work that we do. We've already kind of talked about this lack of clinical education on substance use, not only in formal training practices, but even at Providence Healthcare. We do 1 hour at general nursing orientation, and there's certain areas that we do some education in their unit specific orientation, but it's still not wide across the board. One of my main things that I feel really morally distressed about in acute care particularly is our inability to keep up with rapidly changing landscape and all the innovations in addiction medicine that are happening in community. So I can give an example. Is we're trying to get hydromorphone tablets for patients to self-administer in acute care. So this is being prescribed at the RAC and also in community. But, you know, we convened a group of all of the stakeholders, and we had a meeting back in the summer of 2021, and we put in a request for a Cerner power plan, so a computerized order set. It's been about 429 days since I put in that request, and it still hasn't been assigned to a clinical informatics specialist. So again, how do we keep up if by the time we're able to get a medication that we're using in community write a nursing DST, ready to roll it out, but meanwhile, community's already moved on to something else. And so how can we kind of respond in a quicker way as we saw sort of with COVID to what's happening. So we do have a new chief nursing officer, and we had a meeting with her yesterday, and it was probably the most refreshing meeting that we've had in a while, because sometimes we just encounter people just saying, no, pharmacy said, no, we can't do that. We can't, you know, it's not like no, but let's try and look at other options. It's oftentimes we run up just against solid no's. And it was so interesting talking with her, and we were talking about some of these challenges, and, you know, she's like, well, I sit at that table, you know, like, oh, okay. Yeah, let's, you know, do I need to talk to Bonnie Henry about this? You know, like, like she's just, it was amazing. We actually started crying at the end of the meeting, but I think like she's super supportive and she gets it. And so yeah, I think it was cathartic, that meeting that we had. And so I'm hopeful. But I think like it's people at higher tables that who have, you know, perhaps, you know, that can kind of move this work forward. The other thing we're seeing is a lack of provincial resources and difficulty transitioning patients to community services. So particularly we have over 3,000 active clients at RAC. And like I said, it's a stabilization clinic. And so we're trying to get these stable patients, of whom we have a lot of transition to community providers, but there's a lack of GPs. There's also a lack of providers willing to maybe take on prescribing opioid agonist therapies. And so we're experiencing some challenges there. We are just two people. We're a mighty team, but we often have to put some things on hold due to limited capacity. And one of the things that we'd love to do more of is research and evaluation, but we just haven't had the capacity. And so a lot of the work that we do is organization-wide, because we see patients organization-wide. But a thing that the CNO brought up is maybe there needs to be a person in professional practice who can be an expert as well in this work, and who can kind of take on some of the queries and some of this work alongside of us. And then, as we mentioned, the lack of safer inhalation space. But I think we'll end on a positive note.
Yeah, one of our kind of pride and joys is that we're doing a full day new grad workshop. So that was identified by Professional Practice, and they actually offer that as a paid learning opportunity for anyone who's a new grad. And we developed that content to try to address specifically what they were saying, you know, was lacking for them. And we've just had really resounding really a great time doing that collaboratively, also with Carlin and many of the other people on the AMCT team coming to join us in for that day. And we've just, you know, it's got a really high level of interest and attendance, especially comparatively for other new grad workshops. And we've also developed an urban health orientation day. So trying to standardize the level of education that nurses receive. Actually, it's interdisciplinary education day for those people that are working in our outpatient urban health clinics. Were you? And yeah, just that we do have these novel opiate agonist therapies with our withdrawal management options. Again, doing training with our site security to the all site security at both St. Paul's and MSJ carry nasal naloxone and have reversed multiple overdoses. And just one thing that, you know, I think that we're always every week, you know, kind of getting calls from people across Canada that are asking us, you know, how do you do that? How do you implement this? Can you share your nursing, your kind of DSTs or your philosophies? And so just really feeling proud of Providence and how much they support this harm reduction work.
And we're also providing safe care, which is trauma-informed care for the whole organization. Even though that doesn't just affect patients who use substances, we've kind of taken that over. And we also do a lot of education around anti-racism, and like sometimes it feels odd coming from us, but if people aren't getting it, it's like we almost feel like we want to make sure people are getting that content, but particularly around trauma-informed care.
Wow, guys, I have to say it's just amazing. It actually even difficult to think about all the different levels on which you're attacking this issue. And I think what I really appreciate is that you centered it in the poisonous drug crisis. It's not versus an overdose crisis where it seems like it's people's choice and whatnot. I really like that lens of the poisonous drug crisis. but it's an amazing amount of work. I don't know if you guys were able to follow some of the chat that's been going on in behind.
Looking at it now.
But yeah, we'll definitely make sure you get a copy of that, because there's lots of great questions and lots of great comments, and it's just an amazing work. Like, you're working outside in the rapid access addictions clinics, you're working in the hospital, you're working with security, you're working with, advocating for the inhalation services. So I am incredibly awed. So wow, thank you. Marcia, do you have anything there?
No, I'm awestruck. I'm gobsmacked, actually, because it is the rapidity of how you were able to bring everything together and continue to show the leadership that is necessary. So congratulations and kudos.
And it's great to hear about the support for your CNO, because we are all big fans, and she's going to be one of our keynotes at our upcoming conference. So that's great too. Wow.
Our old CNO was great as well. We were well supported, but I think she brings like that experience actually from FNHA, which is really interesting. And we're going to strengthen some partnerships there as well. So yeah, this is amazing. Thank you for these comments.
Yeah. Thanks for sharing. Did anyone have any questions? And
we're looking at some of the questions here, and
yeah,
great.
There's I think it's simple, not simple, the benzos complicating overdose response. We've just seen a huge change in the last, I would say, even certainly in the last couple of years, but in the last year in particular. So what we really see, and I mean, this really does have a myriad of impacts, because what we see is this enormous level of sedation. So to the point where a person is completely unresponsive, and that may or may not be correlated with respiratory depression. So certainly we see a lot where people are compromising their own airways. Their level of sedation is so strong that they don't even realize they've cut off their own airway. It's hard to show you on Zoom, but I've come across a few people that even just repositioning, then you realize that they've just blocked their own airway. They don't actually need naloxone. So one of the other complicating factors is, well, as we know, naloxone doesn't reverse that sedation. So you're really kind of watching very closely for someone's return to regular resps, return to, a satisfying oxygenation level, but it's still really unsettling to have a patient who's unconscious. And that can require, I mean, if we see the person go down, we know we have, if it's in the context of the overdose prevention site, then we kind of are quite certain of where that's coming from. But even consider the complexity of transferring that person back to the unit. That person really needs kind of Q15 monitoring, because we just need to continually check that they're protecting their own airway. And so it's an increased workload issue. Or even, in the ideal system, somebody goes to the overdose prevention site, they are able to, inject in a safe way, and then they can sort of carry on after 15 minutes. But if somebody's got benzodiazepine contamination, they could be asleep for 6 hours. I know that this is a big issue in the emergency department, where we see really high doses of Narcan being given in an attempt to try to wake somebody up. And really the result of that is really violent precipitated withdrawal, not ideal. So it is really, it's really complicated. And I think I never thought I would be nostalgic for heroin or a heroin overdose, but I am now.
Well, and the other thing with the benzos is people, we're seeing amnesia. People will not remember up to 48 hours prior.
A complete loss. They don't get it back. And it's incredibly disturbing for the person. And when people are coming from overdoses that have a benzo contamination, it's very distressing, because they probably have no recollection of how they got there, what happened. And they're
even the logistics of space, right? So one of the things, I'm the substance use CNS for interior health, and we're constantly, I think, probably even looping in, and I think my colleague Abby Kala, I think I've asked her to call in to you guys a couple times, even just to say like you said, the benzo naps, the OPS staff are referring to, they're like, how do we get flow through our OPS? We want to be able to, we're turning people away, and it's becoming hugely ethically challenging for them. And just even having a space where they can, kind of offload them out of the cubicle and get them to a space where they can continue to monitor them. And it's hugely logistically challenging, especially as we get into cold winter months where, you know, someone will go, oh, you know, I'll watch them outside. Like, you know, your nursing liability immediately goes up. And so you're torn between this, okay, I have to let this person sleep it off, but also continue to monitor them, but also bring in other people who are arriving to access the site. And so I saw that, you know, obviously you guys are mentioning space issues, and I was just wondering how you're kind of managing like the access and flow of your OPSs with, you know, those prolonged presentations now.
Well, that's one thing that we're kind of missing, that
Chill space.
chill out area. I see your comment about LPN scope. I should have mentioned, so they have access to an RN for clinical support if needed. So oftentimes, instead of calling a code, the OPS nurses will text one of us, and we will actually go to the site and help them manage kind of the overdoses, and also help transport patients back to the units. But yeah, I mean, at our site, like I said, we're only really seeing like 8 to 10 supervised injections a day. So it's sort of, I don't want to say manageable, because the thing that happens is if we're responding or treating someone for an overdose in the OPS, we'll turn people away. And just the other night, I think it was at 6:30, I was still here and Carlin was still here, and she was helping the staff with an overdose in the OPS. And then a code was called in the garden because people had come and they turned them away. And then someone else overdosed outside. So I don't have an answer to how we're kind of managing that. It's certainly, it's tough, yeah. But I don't think we're seeing the same volumes as in community, but.
Yeah. But that must be hard on you when you realize you've turned someone away and now you've got someone who's coding outside. Oh, I feel for you.
Well,
You can't fix the whole crisis on your own, just as 2 people. So just putting that out there.
Yeah, I know that it's hard for we've kind of really tried to work with the nurses at the LPNs at yes, because kind of like continually poking somebody awake is sort of a bit of an aggravating factor. So we try to balance out like how much do you bug somebody to like move on before you kind of like make your own situation happen. So it's a real balancing act of trying to like move people along in a way that's not sort of like rude to them, or kind of making your own complicated situation more complicated. So it's a balancing act. Wow. I like to think that we get through it by supporting each other heavily.
Yeah, and what's really interesting, like, and I don't know, this just came to my mind, is how when we do education with nurses, one of the things that they always mention is something that they really enjoy about the education is around overdose response, and just sort of the nuances around when do you give more naloxone, and you know, like you don't necessarily have to, naloxone isn't the first intervention that we recommend, right? It's airway, circulation. It's like, okay, maybe even like Naomi had said, like when we find a patient who's I'm thinking like in the bathroom, like hunched over, like
this is our intervention.
Our intervention is just holding their head up, right? To open their airway, and they don't need naloxone, but we get it, right? You know, when people, our nurses at the OPS have become, of course, experts in overdose response, but it can be quite distressing. And sometimes people want to just go straight to the naloxone. They just want the person to wake up. And like, of course, like that's kind of how, like, I don't know if you want to say anything about the ED, but it's kind of like, there's
just competing priorities. Like I do feel for the emergency department where we try to coach them on that nuanced response that we can have in a hospital setting to overdose. But I understand that, you know, when you're trying to eliminate sources of sedation, then just continually giving Narcan makes sense. Or if you have a bed flow issue and you really just need to be able to move somebody, you know, is that the best practice for that individual's person's care? No, but you know, we're always nursing within context, right? So I get priorities, and it's really tricky. Wow,
guys, this has been absolutely incredible. So I really do thank you for this.
Thank you so much.
Thank you. Amazing. Lots of hands clapping.
Thank you for joining us. If you would like to learn more about our association, please visit our website at www.cnsabc.ca or follow us on Twitter at CNSABC.